All right, books open, phones off. We are not doing the usual casual chat today. I'm treating this as a crisis meeting, a war room session.
Okay.
I am the panicked student, sweating through my scrubs, maybe 3 weeks before the MD finals, and you,
Oh, you are the senior faculty member who holds the keys to my passing or failing.
please take a deep breath. Panic is probably the first step toward a malpractice suit, and ironically, it's also the first step toward failing your viva.
Yeah, right.
We are going to get through this. So what is the crisis?
The crisis is that I have spent the last 6 months, every waking hour, memorizing the pharmacology of propofol, the physiology of the NMDA receptor, and every single branch of the trigeminal nerve.
As you should.
But I looked at the past papers for the Gujarat University MD exams, the DNB boards, and there it was, this dry but deadly section. Law, ethics, misconduct, it's everywhere.
It is a classic trap. It really is. Students obsess over the science of how to anesthetize, and they completely, utterly neglect the how not to get sued.
Or how not to lose your license. Or how not to lose your license. And I will tell you, in the theory papers, and especially in the Viva, this is where we catch you. You can kill a patient just as easily with a pen or, a lack of a pen as you can with a syringe.
That's exactly what makes it so terrifying.
Nice.
So the mission for this deep dive is, well, it's simple. I need you to prep me. I'm the student, you're the examiner.
Okay.
We have a stack of sources here that we're treating as the syllabus. We've got Miller's Anesthesia, Morgan and McCall, Wiley's Anesthesia, and the DNB question bank.
A solid reading list.
Yeah.
A very solid list. And remember, my goal here isn't just to teach you the law itself.
Right.
It's to teach you how to answer the question. When you see a 10 or 20 mark question on professional misconduct, you need a structure. You can't just ramble on about doing the right thing. You need legal definitions. You need clinical examples. You need to think like an examiner.
Okay, let's do it. Let's start at the very, very beginning. Part A, introduction and exam framing. Why? Why do we even have to learn this? I'm a doctor, not a lawyer. Why is the law scrutinizing us so closely?
Because, simply put, medicine is not just a job. It's something fundamentally different. It's a fiduciary relationship.
Fiduciary. Okay, that's a $10 word. Break that down for me for the exam paper.
It comes from the Latin fiducia, which means trust. It's all about trust. So unlike a business deal where it's buyer beware, caveat emptor in medicine, the patient places their total, absolute trust in you because they lack the knowledge to judge your work.
They have no choice.
They have no choice. And specifically in anesthesia, think about what we do. We render a patient unconscious. We take away their ability to breathe, to move, to protect themselves. We literally take away their autonomy.
We make them completely helpless.
Completely. And that creates a massive, massive burden of responsibility.
Right. If I buy a car, I can, pop the hood and check the engine. If I'm under anesthesia, I can't check if you're watching the monitor. I'm completely at your mercy.
Exactly. Yeah. Because the potential for harm is so incredibly high, the state has to step in. Wiley's Anesthesia makes a great point about this. It says, the state monitors a physician from the moment of matriculation into medical school until the moment they retire.
The whole career.
The entire career. Why? Because the public needs protection from us.
Feels a bit aggressive. Protection from us. We're the good guys.
Well, the potential for error is always there.
Yeah.
And Morgan and McHale have a really sobering stat about that risk profile. They explicitly state, and I'm paraphrasing here, the likelihood of anesthetic complications will never be zero.
Never.
Never. Doesn't matter how good you are. Doesn't matter if you are the head of the department. Even the most diligent practitioner will eventually participate in an anesthetic that is associated with some form of patient injury.
Wow. So it's not a matter of if, but when. That's a heavy realization.
Precisely. And that is why the exam questions focus on this so heavily. If you look at the DNB questions list, you see topics like vicarious liability appearing way back in June 1994.
Wow, that long ago.
Safe anesthetic procedure in December 1999. Medical negligence comes up again and again. These aren't throwaway questions. These are the ones that determine if you are safe enough to be let loose on the public. If you don't know the legal boundaries, you are, frankly, a danger.
Okay, message received. Loud and clear. Let's get into the meat of it, then. Part B, professional misconduct. This feels like a very high-yield topic for a long note.
It is, absolutely. If you get a question on professional misconduct, you have to start with a clear definition. You cannot just list a bunch of bad things doctors do.
So how do I define it? Is it just, being a bad doctor?
No, and this is probably the most crucial distinction you have to make right at the top of your answer. You must distinguish it from negligence.
Okay.
They are not the same thing. Misconduct refers to your behavior. It's about conduct that falls short of the ethical standards expected by the profession. Negligence, on the other hand, usually refers to your performance, a failure in your duty of care.
Okay, I think I get that distinction. So misconduct is I am behaving badly, ethically or morally, and negligence is I am performing my job poorly.
That is a very good shorthand.
Yes.
Wiley gives us a bit of nuance here. It says misconduct can include things like refusing care without a valid reason. It implies a moral or an ethical failing. Negligence, though, it requires a specific breach of duty that results in an injury. So here's the key.
Yeah.
You can have misconduct without ever injuring a patient.
Oh, really? Can you give me an example of that? That's interesting.
Sure. Let's say you show up to work intoxicated. You're clearly not fit to practice.
Yeah.
But a nurse smells the alcohol in your breath and stops you at the door before you can even see a patient.
Okay.
You haven't been negligent, have you? There's no breach of duty to a specific patient, no injury, but you have absolutely committed serious professional misconduct. You have disgraced the profession.
Got it. Okay. So for the exam, I need to classify these types of misconduct. I can't just make a bullet point list of being drunk and shouting.
Correct. You need to show the examiner you understand the legal categories. Use the examiner-approved classifications. First up is infamous conduct.
That sounds dramatic. Infamous conduct, like something out of a Victorian novel.
It's an older legal term, but it's still relevant.
Yeah.
It's often linked to the concept of moral turpitude.
Moral turpitude, another great phrase.
It just means behavior that brings disgrace to the profession. It's conduct that would be reasonably regarded as disgraceful or dishonorable by your professional peers.
So it's judged by other doctors, not by the public.
Exactly. That's a key point. It's a peer standard. Then, a bit more straightforward, we have gross misconduct, which are just severe behavioral violations. And then there's ethical misconduct, which is about violating the specific codes of the medical council.
Like what?
Things like advertising yourself falsely, or, splitting fees with other doctors, which is unethical.
Okay, let's talk examples. If I'm writing this answer, I need concrete examples of misconduct in anesthesia. What's the #1 thing I should mention?
The elephant in the room. Substance abuse.
Right. The sources were pretty heavy on this. Miller and Morgan both have some, frankly, scary statistics. I didn't realize it was such a specific issue for us.
It is the occupational hazard of anesthesia. It truly is. Miller notes that the incidence of substance use disorders, or SUD, in anesthesia personnel is roughly 10 to 20%.
So, similar to the general population.
Right. About the same. However, and this is the terrifying part, the risk of drug-related death for anesthesiologists is twice as high as it is for internists.
Twice as high. Wow. Is that just because of access? I mean, we literally have the keys to the cupboard?
It is largely access, but it's also the nature of the drugs we have access to. We work with incredibly potent opioids, fentanyl, sufentanil, every single day. They are in our pockets. We draw them up. We administer them. We discard the waste.
There's opportunity.
It creates a moment of opportunity that, say, a cardiologist or a dermatologist just doesn't have. Miller points out that while the rate of addiction might be similar, the lethality is far higher because we use the heavy hitters.
And there was this concept mentioned, the re-entry problem. What's that about?
It's a tragic part of this story. It refers to anesthesiologists who get help, they go through rehab, and they try to return to practice.
Which you'd think is a success story.
You would. But the relapse rates are terribly high, especially for those who are addicted to potent narcotics. The environment itself, the smells of the OR, the sight of syringes, the stress, it all acts as a trigger.
So the workplace becomes the danger zone.
Precisely. And Miller suggests that for some, specifically those addicted to injectable opioids, a complete change in specialty might be the only safe solution for them.
Wow. So returning to work might actually be a death sentence for them. That is heavy. Okay, so substance abuse is a major form of misconduct. What else? What's another classic?
Abandonment of the patient. This is a classic exam scenario.
The famous coffee break case.
Exactly. You induce anesthesia, the patient is stable, everything seems fine, and you decide to step out for a quick coffee, leaving the patient with a nurse or a technician.
And then something goes wrong.
And then something goes wrong. If that patient suffers a hypoxic arrest while you are gone, that is not just negligence, that is abandonment. And Wiley points out that this can escalate very quickly to criminal charges manslaughter because it shows a reckless disregard for human life.
So, rule #1, never, ever leave the patient alone.
Never. Continuous presence is mandatory, it's non-negotiable. Another big one is practicing beyond competence.
So fake it till you make it doesn't apply here.
Absolutely not. That's a recipe for disaster. If you take on a complex pediatric cardiac case and you have no formal training in it, that is misconduct. You are accepting a duty you know you cannot fulfill.
And that ties into improper delegation, right?
Exactly. They're two sides of the same coin. Wiley mentioned something very specific about anesthetic technicians.
Yes, I remember that.
This is critical. You cannot delegate the core medical acts of anesthesia to an unqualified person. Wiley states it very clearly. Anesthetic technicians, or aides, are not qualified to provide direct patient care. If you let a technician intubate while you check your phone and something goes wrong, you are liable for allowing an unqualified person to practice medicine.
So that's vicarious liability in a way, but it's also misconduct on my part for even asking them to do it.
Correct. It's your personal failure as a professional. And of course, don't forget the more obvious ones like breach of confidentiality and false certification, signing a fitness certificate for a patient you haven't even examined. Those are easy marks to pick up on the exam paper.
Okay, this is making sense. Let's move on to part C. This
Right.
is the big one. Medical negligence. If I see this on the paper, my brain needs to immediately go to the 4Ds.
For the 4 elements, memorize them. Tattoo them on your brain. It's the absolute foundation. For a plaintiff, that is the patient's lawyer, to prove negligence, they must prove all L4. Not 3, not 2, all 4.
Duty, breach, damage, and direct causation.
Perfect. Let's unpack them. First, duty.
Duty of care.
This is usually the easy part to prove. The moment you accept the patient, the moment you start the pre-op assessment, or the patient enters your operating room, a doctor-patient relationship is formed. You owe them a duty. You can't just walk away.
Simple enough. Second one, breach. This feels like the part where all the arguments happen.
It is. This is where the battle is fought in court. A breach means a deviation from the standard of care.
And what exactly is the standard of care? Is it being the best doctor in the world? Is it being Professor Miller himself?
No, and you must be very specific about this in your answer. Wiley is very clear. The standard is not perfection or best possible care. The legal standard is what a reasonable and prudent anesthesiologist would do under similar circumstances.
Reasonable and prudent. I love these legal phrases, but who defines what's reasonable?
Well, it's defined by the body of opinion of your peers. Essentially, what would a significant number of respected anesthesiologists say is the proper way to handle that situation? If you followed the ASA guidelines, if you did what 90% of your colleagues would do and the patient still had a bad outcome, you likely did not breach the standard of care.
So, and this seems like a huge exam trap.
It is.
A bad outcome does not automatically mean there was negligence.
Correct. That is $1 million sentence right there. Write it down. Complications happen in medicine. Bad things happen even with the best care. Negligence is when you deviate from the accepted standard. For example, failing to use a pulse oximeter during general anesthesia when all guidelines say you must. That is a clear breach.
Okay, got it. Third element,
Oh,
damage.
there has to be an actual injury. This is an interesting one. Let's say I intubate the esophagus by mistake. That is a breach of duty, arguably, or at least a significant complication.
Right, a major error.
A major error. But I recognize it immediately, within seconds. I see no end-tidal CO2, I pull the tube out, I re-intubate correctly, and the patient suffers no harm. No hypoxia, no brain damage, nothing.
So no harm, no foul.
In a legal sense, for negligence, yes.
Yeah.
There is no case for negligence because there's no saccage. You might have been sloppy, you might get a talking to from your head of department, but you weren't negligent in a tort law sense because the patient is whole.
And finally, the fourth one, direct causation, or proximate cause.
The breach must have caused the damage. There has to be a direct link. For example, let's say you failed to check the anesthesia machine properly before the case. That's a breach. During the surgery, the patient dies of a massive, unforeseen pulmonary embolism. That's the damage.
Okay.
You might actually get off on the negligence charge regarding the death.
Wait, why? I made a mistake.
Because checking the machine, while important, would not have prevented the PE. There's no causal link between your specific error and that specific outcome. The lawyer has to prove that, but for your error, the patient would be alive and well.
But I'd probably still get in some kind of trouble for not checking the machine in the first place.
Oh, absolutely. That's probably misconduct, or at least a violation of hospital policy. You'd face departmental action. But it might not be negligence as the legal cause of that specific death. It's a fine point, but an important one.
Got it. Now, you mentioned the locality rule earlier. Wiley says that's kind of disappearing.
Yes, for the most part. In the old days, a country doctor in a small village was held to a lower standard than a professor at a big city university hospital. The law sort of accepted that resources and knowledge were limited.
Made sense at the time.
It did. But that is largely gone now, especially for specialists. A board-certified anesthesiologist is held to a national standard.
Because of the internet, journals, CME.
Exactly. Because of information accessibility. You can't claim ignorance of the latest ASA guidelines just because you practice in a small town. The expectation is the same everywhere.
That's good to know. Okay, now types of negligence. There's civil and criminal.
Right. Civil negligence is a tort of civil wrong. The remedy there is financial compensation. You, or more likely your insurance company, pays money to the patient to try and make them whole.
And criminal negligence.
That's a whole different ballgame. This involves reckless behavior or what the law calls criminal neglect.
Like the coffee break death scenario.
That's a perfect example. Or showing up to work drunk and trying to manage a case. Wiley describes it as behavior showing a reckless disregard for the safety of others. The remedy there isn't money, it's punishment, jail time. The state prosecutes you, not the patient.
And there was a third type mentioned, consumer negligence.
Yes, and in many jurisdictions, including India, where the DNB is highly relevant, medical services fall under consumer protection laws. The patient is viewed as a consumer of your service.
Yeah, consumer. That feels weird.
It does, but it's a legal reality.
Right.
And if the service you provide is found to be deficient, you can be held liable under those laws. It's a parallel track to civil court, and it's often faster and seen as more pro-patient.
Okay, that's a lot to take in on negligence. Let's move to Part D, medico-legal responsibilities. Let's walk through the timeline of an anesthetic. What's our first duty? Pre-op.
The pre-anesthetic evaluation. Miller's very clear here. A proper evaluation is absolutely key, and your documentation of that evaluation is your shield.
What do you mean?
A simple notation in the chart of hypertension is, well, it's insufficient.
It's lazy.
It's legally defenseless.
Yeah.
You need to write something like, hypertension, known for 10 years, on amlodipine 5 milligrams once daily. BP today in clinic 140/90. Good functional status, able to climb 2 flights of stairs.
Be specific.
Be specific. Because if you just write HTN and that patient has a massive stroke on the table, the plaintiff's lawyer will ask, Doctor, did you know how severe it was? Did you check if it was stable? Was the medication working? If it's not written down, the assumption in court is that you didn't know.
If it's not written, it wasn't done.
That's the mantra.
Yeah.
Intraoperative responsibility. You already touched on this. Don't leave the room.
Right. Continuous presence.
Continuous monitoring. And specifically, applying the standard monitors. Both Miller and Wiley emphasize the ASA standards, pulse oximetry, capnography, ECG, non-invasive blood pressure. If you don't use one of them, you better have a spectacular reason why not, and it better be written in the chart.
And post-operative responsibility. Our job doesn't end when the breathing tube comes out.
Not at all. You are responsible for pain management, for monitoring their recovery, and for ensuring they are stable until they meet the official discharge criteria from the recovery room. If you drop a patient in the PTU who is still groggy and apnoic, and you just walk away to the next case, that's abandonment.
Okay. Now, consent. This is labeled absolutely essential for the exam.
It is. It's a huge topic. You must understand the difference between implied, express, and informed consent.
Implied is, if I hold out my arm for a blood draw, that's implied consent.
Yes, your action implies you agree to the procedure. Express consent is verbal or preferably written. Yes, you can do this. But the one that really matters for us, the gold standard, is informed consent.
And that's more than just a signature.
It's a process. That's a key phrase for your exam answer. It's a process. It involves a conversation where you explain the proposed anesthetic, the risks, the benefits, and importantly, the alternatives.
And the consent for anesthesia is separate from surgery.
Critically important point. The surgeon can't just say, sign here for everything. The patient is having 2 separate procedures, really. The surgery and the anesthetic. You need your own consent for your part of the care.
And this is where that terrifying legal concept comes in. Assault and battery.
Yes. It sounds like something from a bar fight, doesn't it?
Right.
But how does a doctor commit battery?
How?
In medical law, if you perform a procedure against a patient's express wishes, it is legally considered battery.
Can you give me an example?
Wiley has a great one. A patient consents to surgery, but says to you very clearly, I absolutely do not want a spinal anesthetic. I am terrified of needles in my back. I only want general anesthesia.
Okay. But let's say I, as the expert, know that a spinal is medically better for them. It's safer for this particular surgery.
Doesn't matter. Patient autonomy trumps your medical opinion in this case. If you get into the OR and you think, I know better, and you try to talk them into it while they are sedated and vulnerable, or worse, you just go ahead and do it. That is battery.
Because it's an unwanted touching.
It's an unwanted touching. It doesn't matter if the spinal was technically perfect and the patient did great. You violated their bodily integrity.
That is a crucial distinction. Negligence is, I did it badly. Battery is, I did what you explicitly told me not to do.
Exactly. And to make it worse, malpractice insurance often excludes battery and other intentional torts from coverage. You could be paying that judgment out of your own pocket.
Yikes. Okay. What about emergencies? That has to be an exception. The emergency doctrine.
That's the defense.
Yeah.
Yes. If a patient is brought in unconscious, they're at risk of death or serious harm, and there's no family or surrogate available to consent. The law implies consent to perform life-saving measures. You don't wait for a signature while the patient is bleeding out.
Common sense, thankfully. Okay, moving on to documentation. My favorite quote from Wiley is here. The faintest ink is preferred by judges to the strongest memory.
It's a brilliant quote. And the other one is the golden rule. If it wasn't written, it wasn't done. In court, 5 years after the event, you will not remember the blood pressure at 10:05 a.m. on a Tuesday. You just won't. The chart is the only witness that never forgets and is always available.
What should we document? Everything, obviously, but what are the key things?
The basics, of course. Vital signs every 5 minutes. All drugs, doses, and times of administration. But also, you must document your negative findings.
What do you mean by that? Documenting something that isn't there.
Yes. If you listen to the lungs and they are clear, with equal air entry, you write lungs clear, BLAE equal. If you've checked the patient's eyes and you've taped them shut for protection, write eyes caped.
Why?
Because it prevents a claim later on that you scratched their cornea or that you missed a wheeze that led to a bronchospasm. If the chart is blank in that area, the lawyer can argue that you never checked in the first place.
And what about errors? If I make a mistake, do I write, oops, my bad, in the chart?
No. Wiley advises extreme caution here. Do not use words like inadvertently or accidentally in the chart. That is a written admission of guilt.
So what do I write instead? I can't just pretend it didn't happen.
You record the objective facts. For example, 50 milligrams of rocuronium administered. Patient subsequently developed widespread rash and hypotension to 70/40. Do not write given wrong drug by mistake. Just state the facts. Let them speak for themselves.
And never write anything bad about colleagues in the chart.
Never, ever. Don't write things like, surgeon was clumsy and hit the aorta.
Right.
You write, sudden increase in bleeding from surgical field. Aorta subsequently clamped. BP dropped to 60/40. Don't fight a war in the margins of the medical record. It looks incredibly unprofessional and it hurts the legal defense of the entire team.
Okay, that makes sense. Let's shift to Part E, the legal framework. We mentioned vicarious liability. Can we expand on that?
Sure. The legal term is respondent superior, which means let the master answer. In a hospital context, the consultant can be held liable for the errors of the resident or the nurse if they are supervising them.
Is that the captain of the ship doctrine I've heard about?
It's an older concept, and it's evolving. It used to be that the surgeon or the lead anesthesiologist was considered the captain and was responsible for everything and everyone in the OR.
And now?
Nowadays, the law is moving more towards individual responsibility. Everyone is accountable for their own actions, but the supervisor is still liable for things like improper training or, crucially, incompetent delegation. If you ask a junior resident to do a procedure you know they're not ready for, you are still on the hook.
And what about our role as an expert witness?
If you're ever called to court as an expert, your role is very specific. Your job is to define the standard of care for the judge and the jury, because they are lay people. They don't know what's normal practice.
So you're there to educate the court.
Yes. And you must be honest and objective. You are not there to be an advocate for the defense or the plaintiff. You are an advocate for the truth of what constitutes standard medical practice.
Okay. Part F, defenses. How do I defend myself if I'm sued?
Your number one defense, your shield, is, I adhered to standard practice. If you can show through your documentation and testimony that you did what any other reasonable anesthesiologist would have done, you will most likely win. This is why following guidelines is so important.
What's the second line of defense?
Informed consent. The patient was aware of this specific risk and accepted it. A classic example is tooth damage during intubation. It's a known common complication.
So if I warn them about it.
If you documented that you warned them about the risk of tooth damage,
Mhm.
and they sign the consent form, and then a tooth unfortunately breaks despite your careful technique,
Yeah.
you have a very strong defense.
Mm.
It was a recognized complication that they accepted, not an act of negligence.
What about contributory negligence?
This is when the patient themselves contributes to the harm. The classic example is the MPO guidelines. You told them nothing by mouth after midnight. They decided to have a full breakfast, lied to you about it, then vomited on induction and aspirated.
So their actions contributed to the bad outcome.
Directly. That's a powerful defense. And then there's the emergency doctrine we already discussed, acting to save a life without time for formal consent.
Okay, that feels fair. Part G, risk reduction. Prevention is better than cure. How do we stay out of court in the first place?
Protocols and checklists. It's all about systems. Miller references that famous report, "To err is human." We know humans make mistakes, so we need systems to catch them. Use the pre-anesthetic checklist every single time. Verify your equipment.
Equipment checks seem like a big deal in the practical exam.
They are. And Miller specifically mentions checking the low-pressure system for leaks. Do you know where that is on the anesthesia machine?
It's downstream of the flow meters, right? Before the common gas outlet.
Correct. It's the most vulnerable part of the anesthesia workstation. It includes the vaporizer back bar.
And why is a leak there so particularly dangerous?
Because if there is a leak in that part of the system, the fresh gas you have just carefully mixed, including the oxygen leaks out into the room before it gets to the patient circuit. But your flow meters, which are upstream, will still show that you are delivering 100% oxygen.
So you think you're giving oxygen?
You think you are delivering a life-sustaining gas mixture, but the patient is actually getting nothing, or hypoxic mixture. It's a direct cause of hypoxic brain injury.
That's a very specific technical detail that I can see an examiner loving.
It is. You must know how to perform a low-pressure system check. It's often called the negative pressure leak test.
Okay, good to know. What are some other common medico-legal pitfalls?
Positioning injuries. They are huge. Miller and even anatomy texts like B.D. Charasia highlight this. Peripheral nerve injuries make up something like 22% of closed claims in anesthesia.
The ulnar nerve. It's always the ulnar nerve.
It's a classic one. The ulnar nerve at the elbow. It's very superficial, running in the cubital tunnel right behind the medial epicondyle. It's so easily compressed against a hard, unpadded arm board. If a patient wakes up with a claw hand or numbness in their little and ring finger, it is very hard to defend if you didn't document proper padding and positioning.
And dental damage.
Very, very common. Usually the upper incisors during laryngoscopy. The best defense is a good offense. Document if they had loose teeth, crowns, or poor dentition preoperatively, and use a tooth guard if you're concerned.
And the ultimate nightmare scenario, awareness under anesthesia.
A terrible complication. And as Wiley notes, it is incredibly hard to defend unless you have a perfect, unbroken anesthetic record. If there are gaps in your end tidal agent recording, the lawyer will argue that the vaporizer ran empty and you simply didn't notice. You need to prove you were delivering an adequate dose of anesthetic agent continuously.
All right, let's bring it all home. Part H, exam integration. You said we need to draw tables.
Yes. If you are writing a long theory paper, a table is your best friend. It breaks up the wall of text and it shows the examiner you have clarity of thought. You absolutely need to be able to draw a table comparing misconduct versus negligence.
Okay, walk me through the columns and rows for that one.
Simple. Column 1, misconduct. Column 2, negligence. Row 1 is focus. For misconduct, the focus is on behavior and ethics. For negligence, it's on performance and duty of care. Row 2 is intent. Misconduct often implies a degree of willfulness or a moral failing. Negligence is usually unintentional carelessness. Row 3 is outcome. Misconduct does not require a patient to be injured. Negligence must have injury, the damage component.
That's a perfect 5-mark table right there.
Yeah.
What about civil versus criminal negligence?
Another great table to have in your back pocket. Civil liability versus criminal liability. Row 1 is the nature of the wrong. Civil is a tort, which is a private wrong between individuals. Criminal is a crime, a public wrong against the state. Row 2 is burden of proof. This is key. For civil, it's preponderance of the evidence, which basically means more likely than not, 51%. For criminal, it's the much higher standard of beyond a reasonable doubt. Row 3 is the penalty. Civil penalty is compensation, usually money. The criminal penalty is punishment, like imprisonment or a fine.
Fantastic. Now, for the Viva, the traps. You're the examiner. You want to see if I really know my stuff. What do you ask me to make me stumble?
I look you right in the eye very seriously and I ask, Doctor, you followed the guidelines perfectly. You were extremely careful. But despite your best efforts, the patient died on the table. Are you negligent?
And I take a breath and I say, no, sir. If I met the standard of care, a bad outcome is a recognized complication, not an act of negligence.
Perfect answer. Then I'll try another one. Doctor, you are a second-year resident. You are doing some moonlighting work as a consultant at a private nursing home to make extra money. You make a mistake. In court, are you judged by the standard of a resident or a consultant?
Ooh, that's the resident trap. I remember this from Wiley. I am judged by the standard of the post I hold. If I am acting as a consultant, I am judged as a consultant.
Correct. You cannot hide behind the excuse of, I'm just a trainee, if you have accepted a consultant's role and presumably a consultant's pay. You are held to the higher standard.
What's another trap? Something to do with documentation.
Yes. I hand you a photocopy of an anesthetic chart. There are empty spaces for the blood pressure recording for about 15 minutes, right in the middle of the case. I ask you, what happened here?
And if I say, oh, I was busy resuscitating the patient who was crashing.
Then I will say, then how do I know you didn't just go for a coffee? How do I know you were even in the room? Gaps in the record are legally indefensible. They imply either abandonment or a complete failure of monitoring. You must document, even during a crisis.
Diagrams. Can we actually draw diagrams for a law and ethics question?
Yes, examiners love diagrams. It shows structured thinking. Draw the chain of causation for negligence. It's a simple flowchart. A box for duty, an arrow, a box for breach, an arrow, a box for injury, an arrow, a box for proximate cause. You can even put a big red cross through one of the arrows to show that if any link is broken, it's not negligence.
That's a great visual.
You can also draw a timeline of the duty of care. Just a horizontal line. Start on the left, pre-op assessment. In the middle, intra-op monitoring. On the right, post-op handover and discharge. On the right. And you can list the key duties under each point. It looks professional, and it saves you from writing dense paragraphs.
Okay, let's summarize this entire session. Give me the final take-home points for the exam, the absolute must-knows.
Okay, 5 key points.
Medicine is a fiduciary relationship. Start your long-form answer with that sentence. It shows you understand the core principle.
Documentation is your best defense. Remember the quote, "The faintest ink is better than the strongest memory."
The standard of care is reasonable, not perfect. You are not expected to be superhuman.
Consent is a process, not just a signature. It's a dialogue.
Know the difference. Misconduct is behavior. Negligence is performance.
And finally, any advice from the senior faculty for the actual exam day, the mental game.
Keep a cool head. It's exactly the same as in the operating theater. If you panic in the exam hall, you will make silly mistakes. Read the question carefully. If they ask about misconduct, don't spend 15 minutes writing about negligence. Define your terms. Quote a source if you can, saying, according to Miller's anesthesia, looks very impressive. And above all, remember, you are training to keep people safe. The law is just the framework to ensure you do that every day.
But it helps a lot. It makes it feel less like a trap and more like a safety net.
Exactly what it is.
All right. I think my panic is subsiding. I'm going to go draw those comparison tables right now while all this is fresh in my mind.
That's a very good idea. And maybe do a quick check of the low-pressure system on your anesthesia machine tomorrow morning, just to be safe.
Will do. Thanks, Professor. I feel a lot better.
You should. You know this material. Good luck.
And to all of you listening, thanks for joining this high-stakes revision session. Hopefully we've helped keep you out of court and firmly on the pass list.
And here's a final thought to chew on as you study. We've talked a lot about documentation, about the faintest ink. Miller mentions the computer-based patient record. As AI and automated record-keeping enter the OR more and more, and those records become absolutely perfect second-by-second accounts, will the standard of care begin to shift? If a machine records every tiny microdeviation in blood pressure that a human might reasonably miss or average out, will reasonable human error become harder and harder to defend? Something to think about for the future.
A slightly scary thought to end on. We'll see you next time on The Deep Dive.